Oh, Dr. Lee, would you be able to share the slides again?
Okay.
Thanks.
Oh,
All right. Hi, everyone. This is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. Please feel free to introduce yourself in the chat box. Next slide, please. I just wanted to review a few housekeeping items with you all before we begin. Participant microphones have been muted at entry, and you'll be able to raise your hand during the discussion portion to be unmuted using the chat feature. And during the presentation, if you have any technical difficulties or questions about the topic, please use the chat box. This webinar is being recorded and will be available for viewing at a later time on the MHTTC website. And those attending today's live event will be eligible to request a certificate. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. Our team is composed of the Yale Program for Recovery and Community Health in partnership with C4 Innovations, Harvard University, and the Center for Educational Improvement. Our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. And to ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And with that, it is my pleasure to hand it over to Dr. Raquel Meshlam-Gately for introductions.
Thanks, Rachel, and good afternoon, everyone, and thanks for joining us today. My name is Raquel Meshlam-Gately. I am a psychologist from Beth Israel Deaconess Medical Center in Boston, involved with the New England Mental Health Technology Transfer Center. I'd like to welcome you to today's discussion and question and answer session, which is part of an important series of initiatives we've launched through the New England MHTTC to address culturally competent care for people with serious mental illness. We're going to be regularly updating these initiatives on our website, and we'd welcome any suggestions for other resources that we can provide. As I'm sure you're all aware, cultural factors have a range of implications for mental health practice, including access to care, treatment-seeking patterns, lack of trust and stigma, the nature of the therapeutic relationship, and issues of racism and discrimination. These considerations may be particularly heightened for those with psychosis. And as a field, we're tasked with creating equal, culturally sensitive care for all. So to that end, we've invited Dr. Hui-Jun Lee and Dr. Yolanda Bogan to address this important topic. We invited them through a webinar on December 16th of 2020. They gave such a wonderful and engaging presentation that stimulated so many questions and comments that they didn't have enough time to address all of them. So we invited them back for this discussion and question and answer session, which will also include some slides and cases to guide the conversation. There are also some previously submitted questions that we'll include today. However, if you didn't have a chance to submit any questions or comments beforehand, we welcome you to do so today, as this is really meant to be an interactive session. Please also feel free to share comments and questions about any de-identified cases in which cultural competence has played or is playing an important role. You can type your questions and comments in the chat box, or you can raise your hand and unmute yourself and share your video later. So just a very brief introduction for Drs. Lee and Bogan. Dr. Lee is an associate professor in the Department of Psychology at Florida A&M University. She is a nationally certified school psychologist and youth mental health first aid trainer. Prior to joining Florida A&M University, I was privileged to work with Dr. Lee when she served as the Director of Multicultural Research for our Psychosis research program at Beth Israel Deaconess Medical Center. She's received federal and foundation grants to conduct qualitative and quantitative research on psychosocial factors related to mental health, such as culture-specific beliefs about causes of mental illness, stigma, and barriers to services among individuals from diverse backgrounds. Dr. Lee has also been receiving federal funding to study risk factors and symptoms of youth at clinical high risk for psychotic disorders. And Dr. Bogan is a professor of psychology and director of research and assessment in the College of Social Sciences, Arts and Humanities at Florida A&M University. She also previously served as the university's program director for the Center for Interpersonal Violence, Intervention and Prevention, as well as its director of the Women's Center and Counseling Center. Her mental health advocacy projects have been funded by SAMHSA, the Office of Women's Health, and historically Black Colleges and Universities Center for Excellence. She is a licensed psychologist and has long studied and provided therapy services related to women's issues, including depression, sexual assault, substance abuse, and women's health. She is an emeritus member of the Association for University and College Counseling Center Directors, and she is the CEO and owner of Dr. Yolanda Bogan and Associates, PLLC, a culturally competent psychotherapy practice. She has authored many articles, book chapters, and conference presentations focused on the African American culture and mental health. So, without further ado, it is my great pleasure to turn things over to Dr. Lee and Dr. Bogan.
Thank you so much, Raquel, for the wonderful introduction, and also thank you all to be here. And also, I think many of us were in the December 16th session, and welcome back. And we are very excited to maybe discuss more about culturally sensitive practices when we work with our clients. And we are sure that during our discussion, there may be more questions than answers. So I will start. So these are, again, things that we will briefly review, and both Dr. Bogan and I will share a case or two of our kind of cultural background. And hopefully the strategies that we use to work with those patients and the families are considered as culturally sensitive and also culturally competent care. And some of the strategies may apply to mental illnesses in general, and maybe psychosis in particular. So this is, again, a review of what we presented in December. So basically, mental illnesses are really affected by different factors, including the psychosocial factors and also triggers to the clinical symptoms. Of course, the psychosocial factors could include the person's cultural background, practices, religion, education or economic status, and beliefs about mental illnesses, which are socially, culturally kind of influenced. And so those can contribute to their explanation or even symptoms of some mental illnesses, along with the clinical triggers and the symptoms. And I will start with working with the Asian Americans. So again, this is a quick review of what we talked about in December, some of the barriers to mental health services. So according to the big data, in many cases, mental illnesses in Asian American populations, the prevalence rates are not higher than the majority of the population. But their help-seeking behaviors disproportionately is lower. So these can be considered as some of the barriers to services. Again, this on the list. And also if they do come to seek mental health services, they tend to have a higher attrition rate. They leave the sessions early due to the different kinds of reasons. And of course, therapeutic relationship is really related to us because many of us are maybe in the frontier or pioneers of the clinical work. And some of the cultural nuances that we may need to attend to that can really keep our clients longer in treatment. And here again, a review of some of the challenges in treatment efforts. So these are, again, there are always individual differences. Maybe in general, Asian Americans tend to take a passive role in, especially mental health services, and expecting the clinicians to take a more direct authoritarian role to just tell us what to do. And in terms of the relationship, it's less kind of a respectable but remote, quick fix. So that's why if they don't feel like they are being helped in the first or second sessions, they may not come back. And they expect their long-standing problems to be just fixed in 1 or 2 sessions. It's very outcome-oriented. Of course, we so as families and the clients, maybe we can understand their kind of hopes to solve their problems. So again, as clinicians or social workers or the mental health system, so whenever possible, when we provide the services, if possible, in a non-stigmatizing setting, especially maybe in the names of our clinic, our services. So maybe, for example, in the Boston, the Chinatown area, they have a behavioral health center. They don't call it mental health, behavioral health. And so basically, yeah, in where it's located and how we name the service might be also relevant, affecting their willingness to seek help. And the long list of barriers, so we may want to address them directly. Not all of them, maybe in 1 or 2 sessions, but the most concerning barrier, we may want to address them. But again, I'm sure most of us have been doing this, but just as a kind of a common practice. This conduct therapeutic relationship assessment is very critical because in many cases, for many Asian Americans, they may not be openly expressing or express their opinions or attitudes or what they think about the doctors in white coat. So because out of respect, so an honest view from the patients and families are very important, but not very easy to get from them. But that's something that we can keep in mind. And also patients, parents, out of respect, they often indicate a yes or willingness to follow your kind of treatment or suggestions or recommendations. But when in reality, they may think differently and they may do differently. So again, whatever treatment that we can make as more culturally sensitive or relevant. So that kind of aims we can strive to do. So again, these are the things that we talked about last month in December. So also due to the reason that many, again, not always, Asian Americans families, they come to see us when the situation is getting very severe. So again, they expect us in the first session to provide something tangible for them to take home. So whenever possible, please take the intake session as intervention session instead of only information gathering. So they may feel that, so it's all I'm talking, but I didn't get anything help from the system. So again, take intake session as intervention session might be helpful to at least maybe alleviate some of the symptoms or inviting them to come back. And whenever possible, based on our clinical judgment, so do kind of a suicide homicide risk assessment, given the situation that they come to us under extreme stress. And whenever possible, provide some tangible solution to them each session. Okay. So here, we have a case here. So this is on 2 slides. So maybe all of us take a few minutes to review this case, and also keep in mind, if you were the clinician, how would you approach this case to work with this young man and also the family? So I'll give you a few minutes. Okay, I'm going to everybody needs a little bit more time. Let me know if you need more time. If not, let's go to the second slide. Still the same case continued. Okay. Yeah, so basically this is a brief scenario about Ming's complaints and what he was experiencing. And also some of his family, culture, immigration, and related background. So maybe at this time we can open up. You can maybe unmute to share your kind of information and how you would approach and work with me and the family. We can do this open discussion section. So in this case, is not basically is we put together the information of several people's symptoms into this particular case. Is not representing one particular child.
I guess I have a question. I'm not sure. But I'm thinking if I'm meeting with a young person who is probably starting to show some symptoms of psychosis, right? Mm-hmm. But early on, you're never certain, right? And so I'm trying to sort of think in my head, the approach that I typically take is, let's talk through all these different possibilities and let's think about all these different options and let's kind of like talk about different treatment options, but I'm mindful that that doesn't put me in much of an expert position, right? So I'm trying to figure out, how do I expertly, take the role of the expert in a way that's still sort of weighing all these different uncertainties in my mind. Does that question make sense?
Very, very, very much. Yes, especially with the symptoms of the warning signs, of psychosis. So there are so many factors or possible reasons, right? Or is it the symptoms, or is it other things or drug related? That makes a lot of sense. So maybe exploring the with the child. So what has been going on in the past month or two or few months over the semester will be helpful. Okay. Yep, very good. So any other things that maybe in your clinical practice or work? So when you meet a case, when you have a case like this.
Perhaps this was already said. I'm calling from Michigan, but I always want to ask people how they understand what's going on, what's their kind of understanding about it, what are they making of it, what does it mean to them? Because then I think sometimes you can kind of become have more access to kind of culturally how they're explaining it and how they're coming to make sense of it.
Yes, I think that's very good. So that's the context, cultural or psychosocial context, how they understand their experiences. So maybe for parents, for other people, they may not at that time consider as certain symptoms, but maybe experiences. Have them explain their experiences. Okay, very good. Thank you.
And then I think expanding on that, just also asking like, what is bothering the person? Because I might consider something a symptom, but if it's not bothering them, then, it works for them. It's okay. But, seeing some of the way that he's explaining, I think it's this blood flow to my, extra blood flow to my brain. Okay. Is that bothering you? Is that something we need to work on?
Yeah, exactly. So because he is experiencing a few things, what is the most worrisome? Okay, thank you. So anything else?
I would also say maybe this is what I already said, but you want to know kind of what is their orientation toward Western medicine? What is their, because these medications may not be within the realm of kind of something they would consider an intervention that would, or a support that would feel okay in any way, shape, or form. So I kind of like to examine what their past experiences have been with healthcare in the United States and what's their overall orientation towards, different forms of, clinical support, let's say.
Mm-hmm. Okay, that's really important, their past experiences. And also, again, so here we do not have the parents in this picture, in this scenario, of course, involving the parents is really very important in any culture to talk about history and also maybe possible family histories and also their experiences receiving mental health services or history of mental health services. So here there's something to keep in mind. So when asking Asian American family about mental health history, so maybe about 99% of the response may be likely that they don't have a person, they don't know a person who have experienced mental health issues. So that does not help us. So maybe some alternative ways to ask family history can be, so are there any adults or were there any adults in the family who did not get married or who did not hold a job or who did not take care of the elderly in the family or in the extended family. So that may bring up that, oh, I have, even though they said we don't have a person who has mental illness, then maybe somebody might remember, oh, remember my uncle, he never got married. He's in his 50s or 40s, and sometimes he talks to himself. So maybe that's mental illness. So, so maybe asking some alternative questions to elicit family history may help. And in terms of mental health services, so they may not go seek help with intention to treat a certain mental illness. So they may, again, go to see their primary care because they have headaches or they have chest pressure or they have nerve breakdowns in terms of they cannot sleep well. So maybe also ask alternative questions in terms of mental health services that may also bring out more information in terms of what kind of services for what kind of challenges the purpose of the service. Yeah, those are very, very good points. Okay. Other kind of things to consider when we work with Ming and the family?
Dr. Lee, there's also a few questions in the chat.
Okay.
And comments.
Yeah, substance use. Yeah. Yeah, and also check whether the symptoms or challenges are worsening or not. Okay, and what? Yeah, those are good questions. We may also inquire the parents what they have noticed about the changes of their son. So most likely what parents started to notice is their maybe their grades, their academic performance. Okay. And so that can be a starting point. So because those, for example, the ears and the flow of blood in the brain and the unusual somatic complaints. So for all that, the concentration on homework, their parents may not be able to observe because it's what Ming experiences. But what they may be able to observe at home, for example, maybe Ming spend less and less time on study, and the homework takes longer and longer time, and the grades are falling behind to compare with, for example, the previous semester. So that can maybe raise alarm to the parents. And also in terms of treatment for this case, so what the clinicians did was, of course, inviting the parents and discuss their concerns. Of course, their parents, the parents are very puzzled by why they were called in, because they didn't see the behavioral, obvious behavior changes besides the academic deterioration. But in their mind, they were saying Ming was just becoming lazy, and he was he was not studying hard enough. So what he could do, Ming, was just to eat well, sleep well, and study harder. The problems will go away. So the clinicians and the social work and also the adjustment counseling provide some level of psychoeducation in terms of how the symptoms or the experiences Ming was having can also help, can also affect the study. So maybe it's not Ming not willing to study, maybe the things that he was experiencing affecting his energy to study. So again, so all cultures value education. So in particular, the Asian Americans. So the clinicians, after consulting Asian American kind of a researcher on cultural related, on cultural kind of sensitivity in terms of mental health care. So they worked with the parents from the academic perspective. So what they are trying to do, in fact, is to help Ming to catch up with the academic performance. So by, for example, providing academic coaches and plans, to-do list, and also some cognitive behavior strategies in tracking the thoughts and the feelings about the blood in his brain, and also to try alternative explanations of the symptoms in order to maybe better either distract or manage the symptoms. And also the clinicians, so with this, they invited the parents to psychoeducational sessions. The parents, especially, mostly the father came with me for 2 sessions, but stopped coming, saying that he had to work because he worked full time. He just couldn't have time to attend the family sessions. So, but Ming, the family supported Ming to come to the individual sessions because they hope that Ming, by attending the sessions, he would do better academically. So, and with the individual sessions, Ming started to open up with the clinicians, the social work, saying that the family, especially the father, really was very strict with him, and often said to me that if you fell behind academically, how would your uncles and aunts think about us? So you are now in the elite high school, but you're not doing well. So it really brings shame to the family. So that's what the parents really worried. So again, so working also with this self-disclosure, the clinicians really also communicated with the parents. So there are different ways to communicate with Ming. But the way that they are saying may not be helpful for me to feel better or feel good. So maybe try some alternative ways to communicate with me. So other things that the clinic did with me was medications. I think somebody mentioned the West medication. So the moment when the medication was brought up by the psychiatrist, the family definitely refused to take any medication. So with that, the clinicians provided some research findings on omega-3 as a supplement to maybe help regulate the mood and the blood flow in the body. So the family started to be more receptive of that, and the Ming started to take omega-3 for some time. So basically different ways that they used to work with me. and they consulted with the Asian American researcher and try to be respectful with the parents. So maybe about 6 months later, Min's symptoms started to get better, and his school performance started to improve with reduced course load, which was very hard for the parents to accept. But they were supportive eventually for Min to adjust his course load and extended time to submit homework. So again, it's a process. It's a long process with Min and with the family. And also in between, they expressed serious concerns about confidentiality, what other people know Min's condition. So again, really assuring confidentiality was an ongoing kind of a thing during the sessions. So again, this is Min, and thank you for your input. And hopefully, again, this is one case, and we all have different approaches and strategies to work with a family based on their background. So it's not a one-size-fits-all strategy. So again, if you have any questions and comments, so you can put on the chat. So next, I'm going to do this one. Self-promotion. So this is a book that was recently published. So me, Daniel Shapiro, and our past Dr. Larry Seidman, we edited this handbook of attenuated psychosis syndrome across cultures. So basically, we invited well-known researchers on this topic from all the continents in this world to share their kind of culturally sensitive approaches working with families and the clients who show risks for psychosis in terms of symptoms, causes of illness, assessment, and intervention. For each of the chapters on this topic, we have a case illustration. So that really puts the case in a context. So again, this is the information here. So next, I'm going to have Dr. Bogan to share her presentation on working with African Americans.
All right, thank you. You can go to the next slide, Dr. Lee. All right, so let's just talk about cultural competence quickly. Here I have a definition that includes having a trusting, affirming space that allows the identification, disclosure, and exploration of distorted thinking that African Americans may adopt from a white dominant society, thereby negatively impacting their mental health. And so some of the issues that would be explored would be the intersectionality of gendered racism, of course, when working with African American women, and including a variety of approaches related to Black psychology. And we'll talk about that very briefly. Next slide, please. So this is just giving some folks a history of Black psychology and some folks that you may want to research. After our December session, I received an email asking for additional information related to folks that may be researched. So I thought I would include that in this presentation. So here are some very early Black psychologists who took an approach to changing psychological policies and protocols aimed at African Americans for the purpose of developing new theories and understanding and explaining behaviors. Next slide, please. And then here we have radicalists or in Black psychology who focus much more on African-centered theories and articulating new sets of principles from which to create new theory and understanding and explaining the behavior of African Americans. Again, these are folks that you may want to engage in some additional research on your own. Next slide, please. All right, so one of the things I want to point out is that the Black Women's Health Study has been around for about 25 years. I've been one of the people who've been engaged in that particular study. And one of the recent publications had to do with cognition scores of African American women, and those women who reported having more experiences of racism did poor on cognition. So really just talking about the importance of understanding the harmful aspects of racism and how it affects us. Next slide, please. Next slide. Okay, so let's just talk about Rachel's story. Rachel was a 35-year-old wife and mother of 3 smart and well-behaved daughters, and she presented with insomnia. She reported using a sleep aid, but with no relief. She had a father who also complained of insomnia, and because of that, she thought that her case was untreatable. And because of her lack of sleep, she had problems with her mood, as you might imagine, irritability. She was withdrawn from others. She had difficulty concentrating and psychomotor retardation. She was married, had a very stable and loving husband, but she was often unavailable to her family and preoccupied with work. So she reported anxiety about job loss. And that was related to her preoccupation that she needed to always be accessible and responsive. She also disclosed that she was the only African-American person in her department, and that was a concern for her as well. She reported having more education than her peers, but she felt overlooked at work. She felt like she had to do a lot more than her peers for any type of recognition. And at the same time, she worried about how her peers and supervisor perceived her. Because she was so preoccupied with work, she had very few social engagements outside of her family responsibilities. And so to eliminate her possible work complaints, she reported checking her phone on a continuous basis, including in the middle of the night. So I'm just going to go through some things that I did with Rachel. Next slide, please. All right, so first, I always use a strengths-based approach in my work, and I know many of you already do this, so that's great. So I talked to Rachel about what she was good at. I talked about her level of education. I talked about how important her family support was to her functioning and how good of a mother she was to her children for them to be so well functioning. Next. All right, so one of the things that I also am very mindful of is the importance of talking to patients about recognizing their own humanity. I wanted to make sure that Rachel thought about herself as someone who was deserving of kindness, even to herself. And the idea that she would be so preoccupied with work that she would get her phone in the middle of the night when she would get up to relieve herself. She just felt like she had to be always available. And to the extent, again, that she couldn't sleep at night because she was worried about getting some kind of message from someone at her job that she would have to respond to. So we talked about how she could monitor what she needed to do at work, but also see herself as a human being who needed rest, who needed sleep, and the importance of sleep. I know a lot of patients present with insomnia. So in addition to the regular sleep hygiene that many of us employ, I also talk to them about why they are neglecting their humanity when they don't follow those kinds of prescriptive recommendations. Next slide. So the other thing I wanted to do with Rachel was help her to monitor the kinds of distorted thinking she had about herself, and what might be going on between her peers at work and her supervisor. So I know a lot of us engage cognitive behavioral therapy, and I do as well in the work that I do. But because she talked about being the only African-American person at her place of employment in her department, we talked about how, again, what kind of distorted thinking she may have, or what is the evidence that she has for any kind of concerns she had related to being female and being African-American. Next. So I also talk to her about non-materialistic values. We live in a very materialistic society, and I explored with her what is important to her in terms of her overall life. And she talked about her family functioning well. She talked about what she was modeling for her daughters in terms of her lack of access or lack of psychological, social, emotional access. She was present physically, but not mindful. And I know that all of us have met with patients who spend a lot of time not being in the present. And so we talked a lot about that. And I also explore with my patients punishment. We live in a society where there's a lot of punishment, particularly to African Americans, and how is it that we internalize that punishment of self? And so I talked to her about what or how that might be present in what she was doing to herself by not allowing herself to be human, to allow herself to sleep peacefully, by thinking that she was a machine and having to be responsive all of the time. Next. Again, incorporating spirituality is something that we talked about in December, but it's also a very important part of the work that I do with my African-American patients. You'll find lots of literature that talks about how African-Americans are much more likely to be spiritual. And so we talk about their beliefs in God, and we also talk about their faith and what their faith means to them. A belief in God is one thing, having faith is another thing. And so we talk about the difference between those two and how those impact the kinds of decisions they make in their belief about even their recovery. So I also engage a holistic approach to working with my patients. Again, I talked about quality of life earlier, those non-materialistic values. I bring in literature that's specific to African Americans. And this was just one other study from the Black Women's Health Study that was published last year that talked about the importance of exercise. And so that's something that I monitor with my patients on a regular basis. How much are you exercising, and helping them to understand that you don't have to engage in strenuous exercise. You can walk on a regular basis, and that does have benefits for your mental health. Next. So my point is that culturally competence is much more than having things on your wall that depict African American culture. It's just a way of exploring the mind, character, and spirit in lots of different ways by looking at sense of isolation, a sense of worthiness, a sense of value of a person's humanity, and allowing them the space to not just mention issues related to race and sex, but really helping them to explore what those things mean on a deeper level. So with that, I know that we're almost out of time, but we can open it up to a few questions. We've got some take-home messages here. Be aware of the barriers of Asian American clients' experience. Consider cultural influences on African Americans. Of course, when we talk about cultural influences, we're not just talking about African American culture, we're also talking about the larger culture that we live in. Be conscious of the challenges working with these clients, and strive to provide culturally sensitive mental health services. And when in doubt, consult. So are there any questions that you have for us? We'd be happy to try and answer them.
I have a quick question. I was wondering if asking the client to examine some of her beliefs about her coworkers, about her supervisor, about being the only African American, if that had come from a white therapist, do you think that could have felt like tone policing?
The client brought it up, and so I thought it was important to explore. I think the question is, would she have brought it up if it was a white therapist? And I don't know the answer to that question.
Yes.
I think if the client brings it up, then it's fair to explore that more deeply, because if she brings it up, then it's clearly a concern of hers.
Yeah, thank you.
Uh-huh. Other questions?
Dr. Lee, there was a question to if you can share the last slide again. And also, if any of you included comments before that were not addressed, I was inadvertently kicked out of Zoom, so I didn't catch all of them. Feel free to mention them again, or, you know, like we said before, you can raise your hand to unmute yourself and ask the question.
Hi, I have a question about maybe engaging, particularly for the case example of Rachel, engaging in some of those questions about some of those structures that are a part of white supremacy, that are a part of institutionalized racism. When you may have some ideas like, oh, this is definitely stemming from working in a white supremacist workplace, for example, but the client may not be seeing it in those terms yet. I want to be very careful to not impose my beliefs and like speak for the client, especially as a white practitioner. And I'm wondering what the process of consciousness raising is like. Obviously it's different for each person, but I'm wondering if you could say a little bit about that.
Certainly. I think you ask a very, very good question. And there's been, Ernesto Escado wrote a paper, I can't remember the date of it, but he talked about when there's a cultural disconnect in terms of adherence sort of to mainstream culture, between when there's a difference between the patient and the therapist and what that means. So what I want to add to Rachel's situation was that she shared with me that she was afraid that she might lose her job if she wasn't immediately responsive, and that might be used as a way of terminating her or somehow disciplining her. And we talked about how that would be possible, but what is the likelihood of that happening at her workplace? And so we talked about how often she's ever been contacted in the middle of the night. We talked about how often she responds to people in the middle of the night. And based on the very, very low statistics related to that, then she and I worked together to develop a treatment plan about when she would check her phone. It turned out that she decided not to take her work email off of her phone, but she decided that she would not check it in the middle of the night. And so with that, she continued to, she was then able to sleep, and lots of other things got better for her as well. Your question is related to your imposing your ideas about what would happen. So I'm providing you what happened in this instance because remember, we are letting the patient lead, right? Lead the process. And so you may have those ideas, and we all have these ideas about what may be happening with our patients for lots of different reasons. And so we check it out and we see if it resonates with the patient, because if it doesn't resonate with them, then it's not going to be an effective strategy or theory that we can apply to the treatment, right? So I think it's okay to check it out, but if it doesn't resonate, then we pull back on that. So asking the question, do you think that there might be some other ideas or some systemic issues that impact your experience? And leave it broad and see if they feel that that's the case. I don't think people say that that's the case when they really don't feel it. So it's sort of like as a mom of teenagers saying, here are condoms. I don't think you're going to use them just because you have them. Right? So I do work in HIV/AIDS, so I'm sorry that I make those analogies, but I think you ask an excellent question. Thank you for your question.
I see a question here in the chat. If an individual attributes psychosis to voodoo, what is the best approach in addressing that from a culturally competent perspective?
The idea that a person is attributing their mental illness to voodoo, voodoo is a religion. So what do they mean that they're attributing their psychosis to voodoo? That a hex was placed on them? Okay, so then the question is, do they feel that the hex was placed on them because they did something wrong? So again, allowing the space for the patient to explore what that hex is about. Is it because they feel like they did something wrong? Do they feel like they're being unjustly punished? What is the cultural belief around having that hex to be undone? Do they have to do some kind of penance? So again, helping them to explore their cultural values around that hex and what it means for them, and how do they find relief through formal and informal methods. So of course, going to us would be a formal method, but what are the informal ways that we can get the culture to support what we're doing with the patient so that they find relief? Maybe there's someone in that person's religious structure that could assist in helping them to find that relief, and that might even be part of the treatment plan.
I saw another interesting comment before from a certified peer specialist about also wanting to consider non-medical model coping skills such as wellness recovery action plan, like Copeland, or reality tester from the Pat Deegan Recovery Library. So really interesting and helpful suggestions. Any other last
Well, I'll just say thank you so much for all of you that joined us. Dr. Lee and I were very pleased to be able to follow up our December discussion with you all this morning. We appreciate your interest in culturally competent treatment in mental health. And we're hopeful that the information that we shared with you both in December and today will be fruitful for your edification and for your practice. So
Yeah.
thanks for the opportunity.
Same here. And also, I think some of us may already seen the Q&A answers that we're gonna be provided for your December questions. I think it's on this website, right, Raquel?
And my apologies, I was kicked out of Zoom yet a second time during this presentation for whatever reason while I was speaking. So I was in the middle of thanking both of you again for coming back to present. It was wonderful hearing you speak again, and particularly incorporating both of those cases, which had really important cultural factors to consider in terms of their treatment. So I really appreciate that, and it really helped guide the discussion and questions further too. Thank you so much again.
Thank you all for your time.
Thank you.
Yeah.
Yes, and Rachel, are there any closing remarks?
Thank you all for joining today, and we hope you enjoy the rest of your day.